You decided for me to give this talk, give a talk on this subject. If the tissue valve is in young patients, is it a right choice for India? I can't answer that, but I think we have to answer this ourselves. But what I can do is I can share some of my experience, some of my thoughts on the tissue valves, which I've been using for last more than 20 years. This conflict is always going on with what to choose, the tissue valves or the mechanical valve. But there has been a conventional wisdom among the surgeons that if a young patient use a mechanical valve, if the patient is old, use a tissue valve. Now, how did we get this conventional wisdom, as I say? I think the part of the reason of this wisdom was two historical trials, randomized clinical trials, which were done in late 70s, because when these valves were made available to us in earlier days, surgeons did not know what will be the long-term results of these valves. And I think we are calling it historic randomized trial because after that, to my knowledge, there was no randomized clinical trial comparing tissue and mechanical valves. And both these Edinburgh heart valve trial and Veteran Affairs cooperative studies, it gave the result of both trials showed a small survival advantage of the mechanical valve. And they compared the first generation porcine valve and the Bjork-Shelley valve, they compared the first generation porcine valve and Bjork-Shelley valve, and both valves are now obsolete. But what is not obsolete is the impression these trials left in our minds, that the mechanical valve is good, it will last longer, the survival benefits is there, but I think a lot has changed from that time. There is not very little progress in design of mechanical valves in the last more than 45 years. We are still using the valve which was developed many, many years back. And but on the tissue section, in tissue valves, we keep hearing about new developments almost every day or almost every month. Some new design change, some anti-calcific treatment, all these things are coming up every now and then. We keep hearing about this tri-leaflet mechanical valve for quite some time, but to best of my knowledge, this has not been yet been launched, and I have not read any report of this clinical use, but supposed to be a game changer in the mechanical valve section. We'll have to wait whenever this is launched clinically. In my experience, like most adult cardiac surgeons, majority of my work is coronary artery bypass surgery, but we do fair number of valve surgeries too. I used to do congenitals, but now there are separate units doing that. And that's my experience of last 32 years. I'm not a basically repairman in valves. Most of my valves are replacements. I do repairs very rarely when they're very straightforward cases, but there are other colleagues of mine who are more in the repairs. So most of the patients of valves go for replacement. Excuse me. And majority of the valves majority of the patients had mechanical valves. But as I said, the last 20-25 years, I have tried to use more and more tissue valves. And these are the numbers. And I use tissue valve in all ages. And it's not the only age, is not the only criteria. There are many other criteria which I decide whether to use tissue or a mechanical valve. And if you see that out of the total number of tissue valves which are used, more than nearly 45% are patients below 60 years of age. I take this consent, special consent I wanted to show because I want everybody to take this kind of a consent for many reasons. Because when we talk to the patient, we just explain everything. But ultimately, when we put the valve, they may come back to us, questioning why we decided this particular valve. So I've decided for last many years, because it happened to us. And after that, I am taking a special consent for whether I'm using a tissue valve or not, after explaining everything to the patients, their whole hands. See, this debate is always on with mechanical versus tissue, and sometimes it is so heated that we almost come to blows among the surgeons that what is a better valve. I don't know about that, but what I find advantages of tissue valve is that, of course, it has a lower incidence of thromboembolism, as you all know. No catastrophic emergencies, which happens in mechanical valve, big advantage in our country especially. No risk of disc impingement, especially in the mitral position, where most of us save the subvalvular structures, we preserve the bodies. There we are always worried in mechanical valve whether disc movements are free or not. The question is, of course, durability, possibility of non-surgical catheter intervention. Once we put a mechanical valve, we take away that possibility of any non-surgical catheter intervention in the future, if at all required. And durability is the question which I think we have to address. There have been multiple reports of very good long-term results. And this report especially was published in 2004 or 2006, actually it was 2004, it was sent for the publication. It shows equivalent late 15-year survival between tissue and mechanical valves. Unfortunately, we don't have our own country data, and that is why we have to depend on the data of Western countries and make our conclusions and decisions. So they show almost equal survival in both tissue and mechanical valve. There are multiple reports like that, which shows quite a good survival and durability of tissue valves. There is no point discussing all these reports separately. I just put them together to show that, of course, you can show many variety of publications where mechanical valves are seen to be superior than tissue valves. If you see the American Heart Association recommendation, note the first line: the patients who cannot or will not take warfarin class 1 indication. I think large majority of our patients come in this class. Patient who cannot or will not take warfarin. And also the line 3, possible compliance problems, again, adds to the our situation more appropriately. This is an interesting study I'm quoting here because this compared the projected future of 30 years of comparing mechanical and tissue valves. And this is on the basis of all the published data. They come out with this conclusion. And if you see the last line, the total risk of morbidity and mortality in mechanical section after 30 years is 108%. That means every single patient who, of course, will have some major complication after mechanical valve if they live for 30 years. We don't see too many patients of 30 years of valve replacement. But in bioprosthetic section, this number is almost half, despite having a redo surgery. So there are some myths which we carry about mechanical valve, and these myths we convey to the patients. And that is, this mechanical valve lasts lifelong. They may, but very rarely. There's no reoperation. That's not true. Mechanical valve also develop significant pannus after 20-25 years, and many of them we have to replace. The risk of thromboembolism is minimal anticoagulation. We know it is not. Coumadin therapy is simple. We know it is not. We tell the patient we have to take one tablet and that's all. It's not that simple. And the reoperation is very risky. Again, we know it is not. They are not anymore. Reoperation is not all that difficult and complicated. The biggest problem with mechanical valve is, of course, lifetime anticoagulation. The compliance consideration of young Indians, I think we have to consider that every time we put a valve. Economic and educational standard, we know. Marriage and childbearing, very important consideration for Indian ladies and women. People don't talk about that, but the busy schedules and earning livelihood, traveling, which is a compulsion for men or for people in young age, I think keeps them away from the medicine, lifelong therapies. Mood swings. Again, nobody talks about it, but we all face it. One fight in the family, one fight with the spouse, and the first thing they will do is stop taking medicines. And there any family trouble, any problem, which often time happens in young people more. I think these are the reasons why they discontinue taking long-term medication. And of course, the medical infrastructure, a lot has to be done still to improve that. I came across this information that there's only about 2,500 labs in India who are NABL accredited. I believe there are more than 1 lakh pathology labs. And after putting the mechanical valve, we are sending the patients in the periphery, and totally their future treatment and life depends on the results from these labs. So we have to be careful where they are going to go and how they are going to be treated, because this is a lifelong situation. It's not a few days, months, and years. Redo valve surgeries, we keep doing. We try doing different approaches. Robotic, we tried 2 cases from some help from proctors. Thoracotomy we used to do earlier for mitral valves or redo cases, but now I have switched back to sternotomies, which is, I think, much better. It takes a little half an hour extra for dissection. Harmonic is very, very helpful in redo situations, and I recommend that please use it. I started using it recently. It has made hell of a lot of difference in dissection in redo situations. The question which I ask myself, question I ask you, question I ask everybody is that we know that all heart valve procedures are palliative. We know that any palliative procedure in body, non-malignant, requiring re-intervention after 12, 15 years, maybe CABG, maybe a PTCA, maybe anything else, maybe a joint replacement in other cases. If they require re-intervention after 12, 15 years, it is considered a good result. We do bypass surgery, a patient requires PTCA 12 years, 15 years later, it's very good. But why do we have a different yardstick for a heart valve replacement? The factors which we are affecting the choice of valve should not be age alone. There are multiple factors, and we all know that your social economic, pregnant, whatever, life expectancy, and we know all that. We all surgeons here. These are the new valves which claiming to be very long durable. They call it the Inspiris Resilia valve. They're claiming that they will work for 25, 30 years. I said I will not be there to see that, but yes. And the possibility of future and more durable valves is always there in the future. This freestyle valve, which I am very happy with this particular valve because I've used more than 120 valves of this kind. This is a freestyle valve, can be used only in aortic position. For some strange reasons, even the Medtronic, which is supplier of this valve, they're also not promoting it very well. But I'm happy because last 20, 25 years, I've never had a chance to redo any of these valves, but this is available only in aortic position. This Foldex, the new valve, which is recently had a trial in India. I was talking to the people who have used this valve. This is, of course, ultimately we thought this is the final solution to the valve problem. These are biopolymer valves, which does not require anticoagulation and expected to last very long. But the clinical trials here done in India have shown some problems, and the aortic position at the moment, I believe, it has been withdrawn because the leaflets stored in some patients. So that's about it. So in conclusion, I would say that the choice of heart valve is a life-changing decision for our patients. It is not such a simple operation. And we should consider the valve very, very seriously, having a lot of criteria about that, what is patient's requirement. Age alone should not be the major criteria. And that's why I believe in fact, yesterday I had a patient who came and consulted me, 36-year-old athletic man, There is a very active life. He wanted to travel, he wanted to do activities, had a severe AR, had developed over the period of time. And I discussed with him, I said, what kind of valve you wanted? And we told everything. Then he himself opted for, no, sir, no problem, I will take a mechanical tissue valve. And we'll have a redo afterwards, who knows? And I think after 10, 15 years, catheter intervention will definitely improve. God only knows what kind of technology will be available to us at that time. But if we put a mechanical valve, we are preventing all that future benefits, if at all, to these patients. The improved durability and the better redo surgery results make the tissue valves more attractive, especially in India. And finally, I think we have to use our brains, of course, but always listen to your heart, because even though it's on your left, it is always right. So thank you very much.